Corneal lesions are important to understand, in particular when differentiating between herpes simplex and herpes zoster keratitis. The use of vital dyes is critically important in this process. Fluorescein is a hydrophilic molecule that pools in defected areas on the surface of the cornea that have been compromised. Rose bengal is a dye that stains for dead or devitalized cells. Using these dyes will help differentiate the cause of the lesion and the ultimate treatment course for your patient. Herpes zoster epithelial lesions are not true ulcers and will thus stain typically with rose bengal and not fluorescein dyes. These are raised epithelial lesions that are referred to as pseudodendrites and again stain with rose bengal dyes. Herpes simplex keratitis will actually cause an ulceration in the cornea that's usually dendritic in nature. It will stain with fluorescein as a vital dye will pool in defected areas of the ulcer. These ulcers have terminal end bulbs. Again, these ulcers stain positively with fluorescein because the virus is an intracellular organism and spreads through the cornea, causing death to the adjacent cells and increasing the size of the ulcer as it progresses. As such, a quick diagnosis and aggressive treatment are necessary in these cases. The standard of care for these individuals is topical antiviral therapy. Trifluridine or Viroptic, as seen on the right, was the standard of care prior to the introduction of ganciclovir gel, which is seen here on the left. Topical trifluridine needs to be dosed 9 times a day until the ulcer healed, then 5 times a day for the next 7 days after that. Ganciclovir gel or Zergan is dosed 5 times a day until the ulcer is healed, and then for 3 times a day for the next 7 days after that. Ganciclovir gel has the advantages over trifluridine of requiring less dosings, and it doesn't have to be refrigerated like trifluridine does. When topical antiviral treatment has been initiated, you can expect relatively significant improvements in signs and symptoms over the first several days. It is important to continue with the therapy as initiated until the ulcer is completely healed before decreasing the dosing frequency. And make sure to see these patients regularly as they are healing. Ultimately, what we're trying to do is avoid permanent scarring on the cornea that can occur if treatment is delayed, as can be seen with this slit lamp evaluation. Remember to use both fluorescein and rose bengal dyes when suspecting herpetic corneal lesions. Realize that herpes simplex causes true corneal ulcers, and it's important to utilize topical antivirals to treat these patients. Understanding appropriate treatment outcomes is critical for successful therapy with these individuals. Keeping these things in mind will help improve patient outcomes, which is ultimately why we do what we do. We hope that this has been clinically insightful.